Welcome everyone. Welcome to the standing orders for vaccination presented by the Hawaii Immunization Coalition and the Immunization Action Coalition. My name is Marisol Abad and I will be your moderator for today's webinar. If you need technical assistance during today's webinar, you may either call the WebEx technical support line at 866-863-3905 or type your technical issue into the WebEx chat feature at the bottom of your navigation bar. If you submit your technical question via chat, please set your chat to send to everyone so that our technical support staff may assist you. This webinar is being recorded and will be available on the Hawaii Immunization Coalition website by the end of the month. Today's speaker is Dr. William Atkinson. Dr. Atkinson is Associate Director for Immunization Education at the Immunization Action Coalition, which he joined in 2012. For 25 years, Dr. Atkinson was a medical officer at the Centers for Disease Control and Prevention, where he participated in a variety of immunization-related activities, including measles surveillance and outbreak control, creation of technical and training materials for vaccine providers, and the development of national immunization policy. From 1995 through 2012, he was the writer, producer, and presenter for 125 national satellite broadcasts and webcasts on multiple vaccine-preventable disease topics. He is the recipient of numerous awards, including the U.S. Public Health Service's Distinguished Service Medal. A question and answer session will follow Dr. Atkinson's presentation. Welcome, Dr. Atkinson.
Today, not from Honolulu or St. Paul, Minnesota, which is where the Immunization Action Coalition is located, but rather from scenic Mountain Home, Idaho, 50 miles southeast of Boise. Long story how I got here. We won't go into it. What I'm going to attempt to do in the next 45 minutes or so is summarize in about 45 minutes what the Immunization Action Coalition did in 4-hour sessions. In 2016, we conducted 25 workshops around the country, 4-hour workshops that basically contained the information I'm going to try to condense down into less than an hour. So with that said, we'll go ahead and get started. First, a little bit of background on the Immunization Action Coalition. I suspect most of you have heard of this and familiar with it. IAC is a 501c3 nonprofit organization that was established in 1994 by Dr. Deborah Wexler, who continues to this day to serve as the executive director of IAC. Our mission is to increase immunization rates and prevent disease by creating and distributing educational materials for healthcare professionals like you and the public that enhance the delivery of safe and effective immunization services. And we produce a wide variety of different types of immunization-related material, most of it directed to you, healthcare providers, but also some to the general public as well. Our website is www.immunize.org. I suspect you are familiar with that. We have a number of publications that are available to you free of charge, such as IAC Express, which is our weekly newsletter. We are a source of vaccine information statements, not just in English, but in about 40 different languages as well. And we have a large number of handouts, mostly directed for healthcare providers as job aids, all of which are reviewed by CDC for technical accuracy, and I'll mention several of those during the presentation. So as far as standing orders are concerned, what we're going to talk about today is what are standing orders and who recommends them, what are the essential components of standing orders, how do standing orders improve vaccination rates, how standing orders benefit medical practices, how to implement them briefly, and some resources that will help you if you decide to go in this direction. First, it's good to talk about what the basic problem is and what standing orders hopefully can help address. Adult immunization rates are unacceptably low in the United States. I won't go into a great deal of detail about that, but for instance, influenza immunization for adults in general is only about 40%, a little better for people over 65. Maternal immunizations and influenza and Tdap are a specific focus due to data showing protection not only of the mother, but also of the newborn infant. Patients aren't receiving their recommended vaccination during office visits. Those who are receiving them are sometimes getting them at their primary care provider, but there are other sources as well, such as pharmacies and health departments where they might also get them. Clinicians really are busy everywhere, Hawaii or elsewhere. Clinicians have to address other issues such as acute and chronic medical problems. They have to do these things first, and oftentimes that leaves preventive health issues such as vaccines as kind of the tail end of that short time that clinicians have to pay attention to it. And so consequently, it sometimes gets dropped or forgotten or otherwise not attended to, these preventive health issues such as vaccines, because of many other issues that are higher priority to the clinician. So consequently, we have lots of missed opportunities when people are in offices but don't get vaccines, and consequently those patients are not protected from vaccine preventable diseases because they're not vaccinated. So the goal of using standing orders is to increase vaccination coverage, mainly by reducing missed opportunities in healthcare settings. And that is done by routinizing and making routine vaccination by making it a program in your office or your clinic rather than relying on an individual clinician's order for every single dose of vaccine. It also empowers nurses and other legally qualified individuals, and I'll talk about this later, to manage your vaccination program independent of clinicians in general. And it will improve, ultimately, it will improve vaccination rates, and it will also help improve efficiency in the office and efficient use of clinician time by freeing up the clinicians from the day-to-day active role in immunization and rather allocating them to a more consultant basis and putting the primary responsibility in other people in the office. So what are standing orders? They're written protocols approved by a physician or other authorized practitioner that authorizes nurses, pharmacists, and other healthcare personnel, that is where it's allowed by state law, to assess a patient's need for vaccine and administer the vaccine without a clinician's direct involvement with the individual patient at the time of the interaction. Standing orders are not new. I'm sure that many of you are familiar with them. Many of you probably already operate under standing orders of some sort. We have been talking about standing orders now for more than 15 years, and many organizations whose job it is to try to improve preventive services, such as the Community Preventive Services Task Force of the Public Health Service, recommends the use of standing orders and has for more than a decade. The Community Preventive Services Task Force recommends standing orders to increase vaccination coverage among adults and children and adolescents on the basis of strong evidence of effectiveness, and I'll show you some of that evidence a little later on. The Advisory Committee on Immunization Practices has recommended the use of standing orders for at least influenza and pneumococcal vaccines since 2000. So it's been 17 years since ACIP recommended that these protocols be used because, again, of evidence that they are effective in raising immunization rates. And finally, the Centers for Medicare and Medicaid Services also are on board, have been for 15 years, since October 2002, when they officially recommended that standing orders could be used for influenza and pneumococcal vaccine. Prior to that time, it actually wasn't allowed by CMS, but since 2002, it has been both allowed and encouraged by CMS to use standing orders for influenza and pneumococcal vaccines at a minimum. But with all this good emphasis and support, and a lot of us talking about this for a really long time, in 2009, a study that was done, a survey that was done by Rick Zimmerman at the University of Pittsburgh and published in 2011 indicated that only about 40% of physicians reported using standing orders for adult influenza vaccination, and only 23% reported consistently using standing orders for both influenza vaccine and pneumococcal polysaccharide vaccine. So, and I don't believe that the situation has improved very much since Dr. Zimmerman did his survey back in 2009. What he also found in this survey was there were certain factors associated with a greater likelihood of a practice using standing orders, and those are, number one, being aware of the HIC recommendations or Medicare regulations regarding adult immunizations, agreeing that standing orders are effective. In other words, it makes sense that clinicians aren't going to use them unless they're convinced that, in fact, they're going to do something, having 2 or more clinical staff per physician, that is a little larger office staff, being a family physician, having an office staff that works well together and is open to innovation, having an electronic medical record, simplifies the process, and having an immunization champion, someone in the practice who is particularly motivated to improve immunization levels, also was found to be an important factor in the use of standing orders. But lack of standing orders implementation may also be due to there being no organizational support. In other words, upper management doesn't agree or doesn't buy in to the concept of using standing orders. Small size of the clinical support staff relative to providers, and concerns about legal ramifications, which was somewhat surprising finding of this survey that I thought that I would digress with just briefly. In a subsequent study that Dr. Zimmerman was involved in that was published in 2012, they surveyed practices that had varying levels of use of standing orders, ranging from they never used them and had no plans to do so, or they used them consistently, and asked what were the barriers that were perceived by the practice about why they did not use, or what was the biggest barrier even if they used them consistently. And one of the surprising findings was as you can see the little arrow there, was a fear of malpractice. And that was particularly notable among those who did not use standing orders and had no plan to use standing orders. That is, that they were afraid they were going to get sued for some reason for use of standing orders or something that could occur as a result of that use. But notice it was concerning even to some practices that use standing orders consistently. So actually, in the commentary of this particular article, it mentioned and recommended that, in fact, there more effort be made to educate clinicians about the availability of the National Vaccine Injury Compensation Program, which essentially alleviates concerns about fear of malpractice. So I thought I would just mention it. I suspect most of you who do vaccines are familiar with the Injury Compensation Program, seeing how it's been around for now 30 years, established by the National Childhood Vaccine Injury Act in 1986, provides no-fault compensation for specified injuries that are temporally related to specific vaccines. It has greatly reduced the risk of litigation for both providers and vaccine manufacturers, and it really has stabilized the vaccine market in the United States since it was put into place. It routinely covers all recommended childhood vaccines, including those administered to adults. So, and interestingly, even if the vaccine is not administered properly, if it was an administration error or given in the wrong route and some untoward event occurred after it, the Vaccine Injury Compensation Program would compensate a person for an injury, even in the case that the vaccine was not used properly. So let's talk for a minute about standing order protocols themselves and what the components are. And I'm going to talk mainly, I'm going to use as my example influenza vaccine standing orders. What you see on the screen is the influenza standing orders that is produced by the Immunization Action Coalition, and we do produce standing orders for all all recommended routine vaccines in the United States. I will go through the components of that and give you some examples here momentarily. Here are what we believe and what is included in all of our standing orders as key components, elements. First and foremost, of course, who is targeted or recommended to receive the vaccine, how to determine if a patient needs or should receive a particular vaccination, that is, indications for the vaccine, contraindications, and precautions, provision of any federally required information, notably the vaccine information statement, procedures for preparing and administering the vaccine, that is, the name, the schedule, the needle size, the dosage, and route of administration, which is particularly important for influenza since there are a number of different vaccines that are given by different routes and also in different dosages. There's also should be an elements that address how to document the vaccine in the patient's record, protocol for the management of the unlikely event of a medical emergency related to the administration of the vaccine, how to report adverse events occurring after vaccination, and then finally a place to have an authorization or signature by a physician or authorized practitioner to put the standing order into place. I'll give you examples of that from the influenza standing order that we produce at IAC. This is the first one. Who is targeted to receive the vaccine? That is, who assessing the actual need for the vaccine. For influenza, this is fairly straightforward because essentially all adults are recommended to receive influenza vaccination. In fact, everyone 6 months of age and older who do not have a contraindication are recommended to get influenza vaccination each year. And we do point out that people who don't know or can't recall if they received the vaccine this year should be vaccinated. A critical element of any standing order protocol and any vaccination program in general is to determine whether or not the person can actually receive the vaccine. Screening for contraindications and precautions is the key to a safe vaccination practice. Section 2 of the standing order does contain specific information about adverse events, about contraindications to influenza vaccines, to both inactivated and, as you can see, actually to live attenuated influenza vaccine, as well as precautions for those. I will mention here as an aside, for the 2017-2018 influenza season, ACIP has again, for the second year, recommended that live attenuated influenza vaccine, or flu mist, not be used for routine vaccination in the United States for anyone. This is going to be discussed again at the October ACIP meeting and could possibly be modified, but as it stands now, ACIP has recommended not to use LAIV. But since some people may and the vaccine may be available, we have left information about live attenuated influenza vaccine on our standing order protocols. One way to make sure that every patient is asked the right questions is to use routinely a screening checklist for contraindications to vaccination. What I'm showing you here is we have a specific screening checklist for contraindications to inactivated injectable influenza vaccine. Notice there are only 4 questions on it, and on the back, since there are very few true contraindications to inactivated influenza vaccine. The second page, shown on the right, does have information about how to translate those answers. The screening questionnaires are intended to be given to the patient, answered by the patient, and then reviewed by the person before they're vaccinated. We added the information on the back to help the clinicians or whoever is screening and administering the vaccine to actually help sort out what could be false positive answers to some of the questions, like, are you sick today, or do you have any allergies? All that written information on the back will help translate some of those what could be confusing answers that patients might give sometime. And those are also produced, by the way, by the Immunization Action Coalition and are available on our website. The third is a recommendation. It's a reminder, really, to provide a vaccine information statement for each vaccine, for each dose of the vaccine that the person receives, preferably in their native language if one is available. And we have many different languages available. BIS has many different languages available on the IAC website. They should be given this before they are vaccinated and not after. This is an example. This is the inactivated influenza vaccine VIS. I will point out, mainly this was to remind you that starting last year, the CDC has modified the VIS for inactivated influenza vaccine so that it doesn't have to be changed every year, so that you are free to use. There have been no changes to the VIS for influenza, for inactivated influenza vaccine for the 2017-18 season. So you can use the VIS that you have left over from last year, if you have any of them left, this year, or it's exactly the same. You can get this probably from the Hawaii Immunization Program, from IAC, from CDC, and they're available from a lot of other sources as well. So it's the same VIS as we used last year. You do not have to wait for another one to be generated for the 17-18 season. The next component is some detailed information about actually preparing and administering the vaccine. And for influenza, this is particularly important, and really for any injected vaccine, it's important to be quite specific about how the vaccine should be administered. For inactivated influenza vaccine, of course, most of these vaccines are administered intramuscularly, so we provide a detailed table that reviews, that summarizes needle length, needle gauge, and injection site for both males and females of varying age, since the length of the needle that you use depends on the gender and the weight of the person being vaccinated. This information is available in other places, such as the general best practices for immunization recommendations that were published earlier this year. We thought it would be a good idea to include this in the standing order so that, in fact, no one would have to look it up. That's the key thing, to have everything right on hand so that nothing has to be searched for and it's all right there. Likewise, specific information, particularly important, again, for inactivated influenza vaccine, is about dose, age groups, since the age groups do vary for some vaccines, again, the route and how to administer it. In this particular part of the table, we include information on the intradermal version of the vaccine, a high-dose vaccine, and also this, actually, I need to update the slide because it would also include the new adjuvanted influenza vaccine, Fluad, which is also like Fluzone high dose, is approved only for people 65 years and older. Both of those are given by the intramuscular route. And again, we do include information about LAIV on this chart, even though I'll remind you again, it's not actually recommended by ACIP to be used during the 2017-2018 season. So this will help avoid, hopefully help avoid vaccine route and vaccine administration errors, which are a common problem during the influenza vaccination season. Information about how to document the vaccine. The vaccination should be documented in at least 2 places, preferably 3 places. Obviously, in your medical record, it needs to be documented. The data was administered, the manufacturer, the lot number, site and route, the name and title of the person administering the vaccine, and you also need to record the publication date of the VIS, the data was given to the patient, and it's also useful if the vaccine for some reason was not administered to record the reason why it wasn't, such as the person had a contraindication or refused to have vaccination. Besides your record, you should also provide the patient with a personal record. We strongly believe that everybody needs to have a personally held immunization record card that will give a future provider an idea of what vaccines a person has received, because patients often don't remember exactly what they had. If, you know, registries, which is the 3rd place, and Hawaii has a registry, and we strongly suggest that clinicians do and offices do participate in the information system that's available in their state or area. But if the patient happens to leave Hawaii and move to Idaho or somewhere else, that personally held record may be the only record that there is. Since even though IISs are great, they don't generally cross state lines. And so that's why we recommend that the patient be given some kind of a record of having received that dose of vaccine so that we'll have it to them in the event that they should leave your practice or leave the state. HIC, you may know, does actually, this is one of the few things that we have that we actually sell rather than give away or have available for free. It's our essentially indestructible adult immunization records that you can see here that has a space to record a lot of different doses of influenza vaccine as well as all other vaccines that are recommended for adults. We would recommend that you provide this or something like it. Many state immunization programs do have record cards available that you might be able to use. IECs are very modestly priced and are very useful to provide the patient with something to take away with them that does record their vaccine dose. You should have a protocol to manage, back up, medical emergencies during vaccination are extremely unlikely. The most likely thing you're going to see if you vaccinate people of all ages is syncope, which is why ACIP has recommended a 15-minute observation period after vaccination now for the last 10 years. But medical emergencies do happen. If you have screened properly, allergic reactions, which is what most people are concerned about, are very unlikely to happen, something like 1 in a million doses. So most of you, if you screen properly, will never see a serious allergic reaction in your entire lifetime of giving vaccines. But that doesn't mean you shouldn't be prepared to manage them. Everybody in your office should be certified in CPR. Very importantly, everyone needs to be very well trained in how to dial 911, and there should be an emergency protocol also available that is reviewed periodically. IAC does produce a medical management protocol. I will mention that it's also available on our website that how to deal with localized reactions, syncope, fainting, anaphylaxis, everything else. I will also mention that we are in the process of updating this. If you are familiar with what the document that we used to call the General Recommendations on Immunization, ACIP has changed its format. It's now called the General Best Practices Recommendations for Immunization, and it's now a completely online document. It was published in May online on the ACIP website, and in that document they included a protocol that was for the management of anaphylaxis, and it differed somewhat from the one that we had, since ours was based on previous recommendations. So we are in the process of updating our medical management recommendations that you see here to be synchronized with the recommendations made in the new General Best Practices for Immunization recommendations that were published by ACIP earlier this year. So we should have that available hopefully in the next, probably in the next few weeks. A reminder that any and all adverse events should be reported to the Vaccine Adverse Event Reporting System. That includes things that happen really at medical events that occur at any interval after a dose of vaccine. Whether you think that they might have been caused by the vaccine or not, it doesn't matter. We have information about how to report to VAERS on our website, and including their phone number and their website you can see here. I would suggest that everybody at least bookmark the VAERS website, since now reporting is encouraged to be done online rather than using pencil and paper and faxes like we used to do, did for a lot of years. You can see here the web address is www.vaers.hhs.gov. It's useful to see. Also on this website is the large table of injuries that are compensable under the Vaccine Injury Compensation Program. But this is the mechanism for reporting any adverse event, any medical event that occurs after a dose of vaccine, and we would encourage you to report those. The other thing about VAERS is that anyone can report to it. You, the patient, lawyers, anybody can report to VAERS And there's a dedicated team of people at FDA and CDC who monitor this on an ongoing basis, looking for any indication that there is an unusual cluster of adverse events. Just as an aside, VAERS has proven its worth many times. It's been around now since 1990, so it's what now, 27 years old, and it was responsible, for instance, for finding the signal for the association of interception with the original rotavirus vaccine, RotaShield, back in 1999 or 2000. So VAERS is very, very useful, is used actively, and is actively monitored by CDC and the Food and Drug Administration. Finally, at the bottom of each one of these is an authorization. Someone needs to sign it, someone who is authorized by state law to allow this policy to go into place. It will usually be the medical director or a clinician in the practice, and it doesn't have to be the medical director or whatever the a clinician who is usually a physician, but not always. The standing order should have an effective date and also should have a recension date. Notice we have a recension date on here. We would encourage you to include a recension date that is an ending date on your standing orders for one primary reason, because vaccine recommendations change, and it's important by putting a recension date that will essentially require you to go and find out when it expires whether or not the standing order has been updated or not. And we have a table on our website that lists the effective dates of all the standing orders that we produce. So it's an easy way to make sure that you actually still have the most current version in place in your practice. As I mentioned, the Immunization Action Coalition has standing orders available for all vaccines for children, for all routinely administered vaccines for children, adolescents, and adults. They're available on our website. They're very easy to find at immunize.org/standing orders, and you can download them all for free. They come as PDF documents that you can use them right out of the box if you wish to. They can also, of course, they are not copyrighted or any way otherwise protected, except that they're PDF documents, and you can use them as they are as you download them, or you can modify them if as necessary to fit your particular practice. So I would encourage you to, this is the place, one of the most common questions we got when we were doing our workshops around the country last year was, we don't have time. We don't have time to develop these things, and now you don't have to because we've done all the work for you, and we also, just as an aside, we revisit these standing orders on a very frequent basis. Actually, every month we review most of the handouts and other documents that are available on the CDC website, and if any recommendations have changed, we make sure that those changes are reflected in the standing orders as soon as possible. So again, this year there weren't a lot of changes in the influenza vaccine recommendations. There were a few changes in a couple of vaccines. For instance, there's now a second vaccine approved 1 to 5 months. The recombinant vaccine is now quadrivalent instead of trivalent. Little things like that. Those have all been reflected now in our influenza standing orders, which have already been posted on the IAC website. And so we will keep all of them up to date as circumstances require, as new vaccine recommendations are made. So I guess all this kind of begs the question about whether this is worth your while. Will standing orders actually improve vaccination rates in your practice? The Community Prevention Services Task Force, which I mentioned earlier, which endorsed standing orders a number of years ago, have done actually more than one comprehensive review of the data, which is kind of what they do. They look at evidence. It's evidence-driven. The recommendations made by the Community Prevention Services Task Force. They reviewed in 2010 or 11 essentially all studies available at that time that examined standing orders either alone or combined with other activities. And what they found was, particularly in regard to adults, if used alone with no other intervention, with nothing else, standing orders increased adult vaccination coverage by a median of 17 percentage points, and in one case, as much as 30 percentage points. So it's a fairly simple way to make fairly dramatic improvements in your adult vaccination rate. If used in combination, it was even more effective in combination of things like reminder recall systems, provider education, that sort of thing. If used in combination with other interventions, a median of 31% percentage point increase in vaccination rates, and as much as 43% in one particular instance. So there's little doubt that these will work based on this. In fact, I think essentially all studies that have ever looked at the impact of standing orders have found them to be effective in increasing immunization rates in all age groups. Here's a specific example that was published in 2005. It was two practices that both had about 900 people in them that were over the age of 65, and they essentially looked at vaccination levels after a season with and without using standing orders. And you can see the two physicians that had 900 patients that standing orders was used, their coverage level at the end of the season was 63% compared to 38% of those patients in the practices that did not have standing orders. This is a little more current and actually addresses adolescents. These are some data generated by Allison Kempe in Denver, where they implemented standing orders for adolescents. And just take, for instance, Tdap at the top. At the national level, at the overall Colorado level in 2013, and then the Denver Health level of vaccination among the adolescents with the use of standing orders, which was nearly 96%. And they also were able to almost double, for instance, the completion rate for HPV and for both males and females compared to both national and outside Denver Health and Colorado levels. So even in adolescents, standing orders have been found to be effective in raising rates. So why should you do this? What's the benefit to you? Well, number one, you're going to free up clinician time because they won't be writing prescriptions for vaccine doses. They won't need to assess vaccination needs and issue orders to vaccinate individual people. Others will take charge of this program. Nurses and other people will take charge of the vaccination program and allow clinicians more time to do what they do, which is to manage acute and chronic medical illnesses, interpret lab tests, deal with prescriptions, etc. You likely will benefit by increasing the number of patients that can be seen, and that could potentially increase your income stream. And by improving vaccination coverage, that stands to reason that you will have fewer susceptible people and hence less vaccine-preventable disease and decreased opportunities for transmission of those diseases in your healthcare setting. People are sometimes anxious about doing this because it seems like it's just going to be too hard. They don't know how to do it. They don't know how to go about implementing it. So we have also tried to address that. It was a big part of our workshops that we did last year around the country to support this, to help guide you if you decide that this is something that would benefit your practice. We have provided a written, essentially, guidebook of how to implement standing orders in your practice. It's also available on our website. It's document P3067 that takes you step by step on exactly what you should do and how you should implement, how you should go about implementing standing orders. And this was an hour-plus talk that I did when I did this live in front of an audience, but I will give you the nuts and bolts of it and tell you the basic steps of implementing standing orders. The first and foremost thing you need to do is get the agreement of the leadership in the practice, your medical director or whoever's in charge of things. If they're not convinced that standing orders are useful, you're probably not going to be successful in implementing them. One thing that can help convince leadership of the need for standing orders is to perform some kind of an assessment of the current immunization rates in your practice. And there's a lot of ways to do this. An IIS, a registry, can help do this. There are software that can do it. You can basically pull some charts. There's a lot of different ways to do it because inevitably coverage levels in a practice are much lower than people perceive they are. And so lower than expected immunization rates in a practice can be a powerful motivator. And so we would encourage you to look at this at the beginning. You need to do it at the end too to see how you did, but to do this in the beginning to help convince leadership and others in the practice that this is a worthwhile thing to undertake. Then you need to identify who will be in charge of leading your standing orders program. You need to find your immunization champion. It may well be some of you listening to me now. You need to, after that, reach agreement about what vaccines your practice will administer using standing orders. If you are not familiar with them, we suggest using influenza as the starting point for a couple of reasons, because influenza vaccination season is fairly well defined. We know when it starts and when it ends. Very few contraindications so this simplifies screening and will help educate your staff so that you can perhaps add additional vaccines at a later date. You will need to create your standing orders for the vaccines that you want to administer. Again, you don't have to do this because the IAC has already done the heavy lifting for you and has already produced the standing orders for any vaccine that you can think of that you might like to provide using standing orders protocols. You need to make sure that everybody in the office is on board with this. So you need to have a meeting with staff, explain the standing orders program so they all understand. You need to also identify who's going to do what. You need to look at the movement of patients through the office and where each of the things such as assessment and screening and the VIS and the screening questionnaire, when those things can be done. And so you'll need to find the staff members who will do those, play those various roles and do those activities as the person moves through the office. Determine your operational strategy. That is, how are you going to do it? Are you going to do express vaccination? Are you going to basically ask everyone who comes in if they've had influenza vaccine, for instance? And there's details on this on the implementation guidelines. Identify some strategies and publicize the program to your patients. Obviously, nothing will happen if you don't let people know that you have this available. So publicizing it on your website or using social media or even old-fashioned stuff when putting a message on hold on your telephone system can help publicize the fact that you now have a high-speed way to get your vaccine in your office. And then basically get going on it, and we're getting close to, we are arguably in influenza vaccination season now, so it's time to get going on it. Your immunization champion will want to watch carefully what's going on until things get working right. It won't work right off the bat. It will take a little practice to find out how to make it work properly and get all the movements of everyone smoothed out. But once it gets going, your immunization champion or your lead person will need to keep an eye on what's going on and make sure that they're always available for questions should any show up. At the end of the season or year or whatever point in time you wish to choose, you should definitely do a progress review, find out how you did. Did anybody have any problems? Are there ways to improve the system in your office? And it's good to look at a after coverage level at that point. However you did it in the beginning to try to estimate the levels of vaccination in your practice, is useful to look at it again. It can be something as simple as how many doses of influenza vaccine did you administer this year compared to last year, or whenever another point in time before you actually started using your standing orders protocols. At the end here, I will mention I can't talk specifically about Hawaii because I do not have this information, but immunization practice, of course, is medical practice, and all states, including Hawaii, have laws governing how physicians delegate medical tasks to other healthcare providers, and who and what and who can do what. There's extreme variability among states. It's amazing how much variability there is about who can authorize it, who can do what kind of supervision has to be done, what kind of settings that standing orders can be done in. No state, to our knowledge, authorizes all non-physician healthcare providers, such as MAs and nurses, to assess, prescribe, and administer vaccines. But there's oftentimes wording in those laws that will help identify who actually can do what and where and under what kind of supervision. The state laws oftentimes address what medical practices may be eligible for delegation, which providers may participate in it, how much supervision is required, and in what settings vaccinations may be administered. So without this information, when we were doing our workshops, we had actually an attorney who would go around and to the states we were in would review all these, and it was quite a job, and it had to be done for every state because every state is different. But at the very least, what you should do is consult with the state immunization program and probably the state medical and nursing boards to determine who is legally qualified to vaccinate using standing orders, who can do the delegation, and if there's any specific requirements for guidance, supervision, or setting. You should probably also discuss standing order protocols with your legal counsel to make sure that they're satisfied, that they know what's going on, and that they comply with all applicable state requirements. And I'm sorry I can't address specifically Hawaii-specific issues, but I suspect the folks in the immunization programs can help you with that if you would like to find out more. So in conclusion, standing order protocols are clearly, after nearly 20 years of experience using these, they improve vaccination levels among adults in a variety of settings. They're endorsed by all major vaccine policy-making institutions. We have materials for you, such as templates and implementation guidance that are ready to use and can help simplify the process, and it will benefit any medical practice. Again, it takes a little effort to get it started, but once it gets started, it will free up your clinicians. It will help improve coverage levels in your practice and will help protect your patient, which is what this is really all about. I'll mention just a couple of resources. I've mentioned several of them already. Immunize.org is the Immunization Action Coalition's website. All the standing orders are there, screening questionnaires, vaccine information statements in a lot of different languages. You can also send questions to us if you have questions about this talk or some others. admin@immunize.org is our email address for incoming general questions. And I'll just mention HIC Express, which is a newsletter we put out once a week on a Tuesday, I think, or Wednesday, one of those. Comes out, I think, 50 weeks a year that will help keep you up to date on what's going on, and you can subscribe to it. We will never, ever share your email address with anybody else except us, and we'll use it only for HIC Express. And again, the standing order templates, and we actually have a specific website that actually does have a lot of this material on it, and links to it is Take a Stand website, standingorders.org. And with that, I will stop talking and see if there are any questions about any of this information.
Thank you, Dr. Atkinson, for your presentation. We'll now begin the question and answer session. To ask a question, please type your question into the WebEx chat box at the bottom of your navigation bar. And please remember to set it to everyone before sending it. We may not get to everyone's question, but we will make sure that Dr. Atkinson reviews all the questions and get you his responses following this webinar. So the first question, Teresa is asking, can people still report if they don't have computer access? And I think we're thinking Teresa is asking about VAERS reporting.
Yes, there is still the availability of paper, telephone. You can actually call VAERS. The number is actually on our standing orders. We we put VAERS phone number there. They realize that some people do not have a computer access and cannot do online reporting, even though it's easy for them to do, and they encourage that at all possible to reduce the amount of paper, but they realize the reality of the situation is some people simply do not have that kind of access, and they can, I believe they can actually take some information over the phone, and they also have a form still that they can mail, that can be filled out by the clinician or really anyone else and mailed back to VAERS. So there are many different ways that you can report something that you think might be an adverse event, either online or by phone or by a written document that you can fax back to them. So the phone number is on the form, and on any of our standing orders forms, you can find the telephone number for VAERS.
Oh, thank you, Dr. Atkinson. Another question we have comes from Dr. Balix. He's asking, does IAC have any learning activities or lessons to help support staff master the team's standing orders approach?
Can you repeat that? Make sure I understand the question. Could you repeat it, please? Sure.
Does IAC have any learning activities or lessons to help support staff master the team/standing orders approach?
Yes, but so do we have any kind of educational material? Yes, we do. We have some training, and it's actually going to be available very shortly. What we literally 2 weeks ago did was we all went to Chicago and recorded what essentially was the entire 4-hour program that had more detail. It was more detailed than this, but it wasn't 4 hours long. It'll end up being maybe an hour and a half when it's all done. So we've actually produced and will be available very soon, and we'll have a link to it on our website, basically a video version that includes background information about adult immunization. It includes information about what are standing orders, and actually then some fairly detailed information about implementation and how that can be done. And it's a 6 or 7 part webinar that can be viewed for free and should be available. Again, it's being edited and finalized even as we speak, and should be available, I think, within the next, probably within the next month. And there also, by the way, is basically an executive summary, because sometimes it may be upper management that needs to be convinced, and there's an executive summary that was done by Deborah Wetzler, who's our executive director of IAC, that summarized all of the content and talked about adult rates and standing orders and how to implement them in a more compressed, 7 or 8 minute presentation. So there'll be information that can be used by staff, and there's also going to be information that can be directed to, say, leadership or management if they need some background on what these are. So check the immunization. I don't know exactly what the timeline for having those posted is going to be, but again, they are working very hard trying to they wanted to get them up by influenza season, so they're working under a serious deadline to get them in. So I'm hoping they'll be available for viewing sometime within the next month. So check the IAC website. They'll be promptly, and also IAC Express will have a notice when they are up and ready to be viewed.
Dr. Atkinson, Dr. Balix also just wanted to comment that perhaps the vaccine-specific screening checklist that you talked about and explanations could be used in an active learning exercise for physicians and their staff, was a comment. Or he wanted to ask if that's possible.
Of course it could, yeah, because you're right, particularly for people who are not used to doing screening or asking these questions, because we expect or anticipate that medical assistants and other people will be asking these questions, which is why we did that. So yes, you could actually use it. In fact, obviously, that anyone who's going to be involved in this and screening people prior to vaccination need to be very familiar with the material, and that's one of the reasons that we try to put fairly detailed information about interpretation of those answers to those questions and what the relevance of the question is as far as a contraindication or precaution. And so there we did had quite a lot of information about that, and that is something that obviously anyone who's doing screening should need to be familiar with before they go into the room. So that's also something that could be used to help educate people, not more in kind of in general for adverse events. And I'll just point out that we have several iterations of the screening checklist. The one that I showed is specific to inactivated influenza vaccine. There's a second one that is specific to live attenuated influenza vaccine, which probably you won't be using, but there also is a more general adult screening questionnaire that has 6 or 7 questions on it that will also include questions relevant to, say, MMR and varicella or zoster vaccine. So you might look at those. So we have, and also we have them for children and for teens. So we have them we have them specific for we have broad general ones, and then we also have those the two that are specific for influenza vaccine that do have quite a lot of good education material included on the second page. It can be used to help educate staff.
Okay. Thank you, Dr. Atkinson. Another question we have is, what types of flu vaccine will be used in Hawaii this flu season?
Well, I'm not in Hawaii, so I can't really tell you that, but maybe I should defer to someone in the Hawaii program about what kind of influenza vaccines that they're going to have available to clinicians there, since I don't really have that information.
Hi, so this is Gail from the Department of Health Immunization Branch. I don't have that information available at my fingertips, but I could put something together that we can send out with the request for you to complete the participation survey at the end of the presentation. So we'll be sending that later in a separate email.
Thanks, Gail. If there's any other questions, we have a few more minutes for questions. If you do have a question, just type it into the chat box again and send to everyone, and we can go through that question. It's 12:56, so we have a few more minutes. If not, I'll move on. We'll wait a few. Well, if no one else has questions, I guess this concludes the question and answer session. Thanks, Dr. Atkinson, for your presentation again. An email with the link of the evaluation survey for this webinar will be sent to everyone. Please take the time to complete this survey, as your feedback assists us in developing future educational opportunities for everyone. And also, just a reminder that this webinar has been recorded, so if someone that was not available to sit in during this session, they can go back to our website at Hawaii Immunization Coalition website to view the recording of this presentation. If there's no other presentations, we will conclude. This concludes our presentation. Thank you for participating in today's webinar and for all the work that you do. And again, thank you, Dr. Atkinson, for taking this time to review your presentation with us. Thanks, everyone.